Hi, my name is Mary Orians. I'm a nurse practitioner at West Cancer Center. I work with our sarcoma specialist, Dr. David Portnoy, who has prepared these slides for us today, but I'll be doing a presentation on sarcomas. So sarcomas are cancers arising from muscle, fat, nerves, fibrous tissue, blood vessels, bone, or other supporting tissues. This is a pie graph just showing how rare sarcomas are, especially in the adult population. They make up less than 1% of all malignancies. They do account for greater than 20% of all pediatric solid malignancies. Almost 90% of sarcomas are soft tissue sarcomas. Bone sarcomas have a very high mortality rate, about 50%. Soft tissue sarcomas have a mortality rate that's a little bit better, a little bit less than 50%. A lot of patients ask us why they got sarcoma. For the most part, we say it's just random. We couldn't tell you why, but there are some that have a genetic predisposition, like patients with Li-Fraumeni or neurofibromatosis can develop malignant peripheral nerve sheath tumors. Gardner syndrome can result in desmoid tumors. Some patients who have had a lot of radiation exposure can develop sarcoma many years later. The mean time is 16 years, and radiation exposure accounts for less than 5% of sarcomas. There are some chemical exposures that can cause sarcoma and infectious causes. The HHV8 virus can cause Kaposi sarcoma. Kaposi sarcoma is almost exclusively found in patients who are HIV positive, and we can actually monitor the efficacy of our treatment by measuring HHV8 levels. Soft tissue sarcomas, they typically present as an enlarging mass. A lot of times it's asymptomatic until it's causing mechanical issues. Intra-abdominal sarcomas may present with weight loss, pain, anemia, or obstruction, especially of the bowels. 60% of soft tissue sarcomas occur in the extremities, 30% occur in the trunk and retroperitoneum, and 10% occur in the head and neck. This is a list of different types of soft tissue sarcomas. As you can see, there are a lot of different subtypes. Cytogenetics have been really important with appropriate diagnosis and treatment and prognostic predictors for sarcomas. Typically, sarcomas were lumped together, and there were only a few different types of regimen, and they were all treated the same. But now with the development of the cytogenetics and being able to determine these mutations, we're able to get a better idea of patient prognosis and a better treatment regimen for them. Initial evaluation usually includes input from a lot of different team members, such as radiology, surgical oncology, orthopedic oncology, radiation, medical oncology, and a lot of times plastic surgery will need to get involved. Okay. For imaging of sarcomas, we like to image the primary site with an MRI. We also do CT chest imaging. Sarcomas typically metastasize to the lungs. Sometimes we do PET CT imaging. We recommend MRI total spine for myxoid and round cell liposarcomas, as they do have a special affinity to metastasize outside of the lungs into the spine. And bone scans and PET imaging is not sufficient to diagnose the spinal metastasis. For really aggressive sarcomas, such as alveolar soft part sarcoma and angiosarcoma, we would consider central nervous system imaging. However, CNS metastasis is rare. And biopsy is the only way to definitively diagnose a sarcoma. Fine needle aspiration is not adequate. Open incisional biopsy would give us a good result, but if not performed correctly, can cause spread of tumor. Core needle biopsy is favored and sufficient. Staging, histology, grade, and size are the most important factors in determining risk of relapse. Lungs are the most common site of metastasis, like we discussed earlier. Lymph node involvement is rare, only in about 5 to 10% of all soft tissue sarcomas. And it does indicate a very poor prognosis. More common in epithelioid sarcomas, rhabdomyosarcomas, and angiosarcoma to find lymph node metastasis. It's about 15 to 20% of the time. And like I said, a very bad prognostic indicator. It nearly equals to distant metastasis. This chart just shows the poor prognosis for those who have distant metastasis or lymph node metastasis. Principles of treatment for soft tissue sarcoma, it's primarily a surgical disease with limb-sparing surgery in greater than 90% of extremity sarcomas. Radiation is often used, especially for extremity tumors that are greater than 5 centimeters in order to eradicate microscopic disease. It is not effective for gross disease. It is beginning to be utilized more in smaller, low-grade tumors. Its use in retroperitoneal sarcomas is pretty unclear, but it can be given pre-op or post-operative or intraoperative radiation therapy. Stage 1 soft tissue sarcomas are primarily treated with surgery. Radiation, if unable to obtain oncologically appropriate margins and without an intact fascial plane, can also observe stage 1A tumors like well-differentiated liposarcoma. Those are generally very slow growing and unlikely to metastasize. However, if we're following a well-differentiated liposarcoma on imaging and we're noticing that it's progressing or looking more aggressive, we will biopsy it to determine if it has progressed to a dedifferentiated liposarcoma, which are more aggressive and more likely to metastasize. We recommend follow-up with physical therapy, occupational therapy, history and physical every 3 to 6 months for 2 to 3 years, then annually. Recommend chest imaging typically every 6 to 12 months. And then consider postoperative baseline and periodic imaging of the primary site of the sarcoma. But this is typically followed by the surgeon, and primary site imaging usually is no longer indicated after 5 years of surgery. These are the NCCN guidelines indicating treatment for resectable stage 2 and stage 3 disease, the indications for surgery, radiation, and considerations of adjuvant chemotherapy. For unresectable or metastatic disease, they can be treated with a metastasectomy, ablation, embolization, stereotactic radiosurgery, palliative radiation, especially for metastatic disease to the spine or bones, palliative chemotherapy, isolated regional limb infusion. We discussed earlier that sarcomas typically metastasize to the lungs. If they only have lung metastasis, it does not necessarily indicate that they need systemic chemotherapy. A lot of times, if they are meeting these prognostic factors, then they will be fine with just a resection of that pulmonary metastasis and become disease-free that way. This is a list. It's not a complete list, but these are common treatments. On the left of this chart is chemotherapies that are useful in multiple histologies. And on the right is histology-specific treatments. As you'll see, there's not a great use of immunotherapy in treatment of sarcomas. But we a lot of times do treat with anthracycline-based combinations with IFEX or doxorubicin alone. This is a list of different type of sarcomas and their chemotherapy sensitivities. In the EORTC study, it compared single agent doxorubicin for treatment of soft tissue sarcomas versus adriamycin IFEX combination in metastatic soft tissue sarcoma. As you can see, the overall survival was only about 2 to 3 months. This is a list of the toxicities, adverse events from the doxorubicin alone group versus the doxorubicin and IFEX combination group. You can see a significant increase in cytopenias and febrile neutropenia in the combination group. The conclusion of the study is that combination therapy is not superior to single agent doxorubicin unless the goal of therapy is tumor shrinkage. For patients that do have metastatic unresectable disease, the size of their tumor does not indicate their prognosis. We do have a lot of patients who are doing really, really well with just stable disease. So if our goal is not to eradicate the disease, it's not possible surgically, then we would just do single agent chemotherapy to decrease the risk of adverse events and side effects. Here I have gastrointestinal stromal tumor, or GIST. It's the most common sarcoma subtype. It originates from interstitial cells of Cajal. It can present in any part of the GI tract, but most commonly in the stomach. Majority of these tumors are positive for the KIT mutation. And here's just a little bit more information about other mutations for the GIST tumor. GIST tumors typically present with bleeding, anemia, abdominal pain, most common in the stomach, then small intestine. Up to 33% present with metastatic disease. They can metastasize to the peritoneum, liver, lung, bone, refractory to standard systemic therapy. If the GIST tumor is less than 2 centimeters and no high risk features, consider endoscopic surveillance every 6 to 12 months. Surgery with or without preoperative imatinib. And then we do recommend adjuvant imatinib for at least 36 months in high risk tumors to decrease risk of recurrence. And then imatinib mechanism of action, it's a selective TKI of KIT, PD, GFR, and ABL. It occupies the ATP binding pocket of the KIT kinase domain, preventing substrate phosphorylation and signaling. Lack of signaling inhibits proliferation and survival. It's the first effective systemic therapy in metastatic disease. The 2-year progression-free survival is 50%. The progression-free survival is better in patients who are able to tolerate the high dose of 800 milligrams versus 400 milligrams. If they're unable to tolerate it, a lot of times we'll decrease the dose to that 400 milligrams. And then 2-year overall survival of 75% in both doses. This has increased the median overall survival from 18 to 57 months. Here we have a list of first line, second line, third line, fourth line therapy for metastatic GIST. First line is imatinib, like we have discussed, and then you can go to sunitinib, regorafenib, or retinib. First, we'll discuss chondrosarcoma, which is a sarcoma of the cartilaginous tissue. It is the most common bone sarcoma in adults. It typically occurs in adults ages 30 to 60, more common in males than females. Presents from the medullary canal or outside of the bone, commonly in the pelvis, femur, or shoulder. Often slow growing, but they can still metastasize. The clinical presentation is usually a dull, aching pain, firm, swollen area. These masses can actually be soft. For a conventional chondrosarcoma, you would treat with surgical excision. If you're able to gain negative margins, you would need to include radiation if positive margins or it is unresectable. There is some efficacy in treatment of chondrosarcomas with pazopanib and regorafenib. There is a risk of late recurrence, and we would definitely recommend chest imaging for at least 10 years. Mesenchymal chondrosarcomas, you would treat like in Ewing's disease, and dedifferentiated chondrosarcomas, you would treat like an osteosarcoma. Ewing sarcoma family of tumors is 6% of the primary bone cancers, typically occurs around 15 years of age. 20 to 30% are metastatic at diagnosis, commonly occur in the pelvis and lower extremities. 5-year overall survival is up to 70% local disease, but only 30% metastatic disease. Typically presents as a vague worsening pain, a mass that's increasing in size, warmth over the mass, flu-like symptoms, fever, fatigue, anemia. Workup with imaging, chest scan, biopsy, MRI, LDH, higher LDH levels typically indicate poor prognosis, and then fertility counseling as the treatment for these can affect. Treatment of Ewing sarcoma includes multi-agent chemotherapy, surgery, and or radiation therapy. Then you would continue chemotherapy post-operatively with or without radiation. And this would be treated with a combination of vincristine, doxorubicin, actinomycin D, IFEX, and etoposide. There are multiple different combination therapies for that. Giant cell tumors are worked up with imaging, MRI site of the primary tumor, chest imaging as they can metastasize as well. You would need a biopsy. If possible, you would resect the disease. For unresectable disease, we are commonly using denosumab now. But there are other treatments such as radiation, observation if it's not causing significant amounts of pain or functional issues. Osteosarcoma is the most common primary bone tumor. Peak onset in adolescence with a second peak in the elderly. It affects more males than females. Lungs are the most common site of metastasis. Usually presents as painful, firm, warm mass, can have limited range of motion or pathologic fracture. Workup with imaging and MRI is very helpful. Need biopsy. We'll monitor LDH to monitor for prognosis, and can actually measure alkaline phosphatase levels to determine kind of treatment response. And then would also need to discuss fertility preservation from this treatment as well. Treat with a wide excision if possible, and consider neoadjuvant chemotherapy with wide excision if the tumor is large. In high-grade osteosarcomas, the 5-year survival with surgery alone is only 10%. The survival rate is 55 to 80% with adjuvant chemotherapy. Response at surgery is prognostic. Consider radiation with positive margins or unresectable disease. You would treat with preoperative chemotherapy, limb-sparing surgery, post-operative chemotherapy in these high-grade osteosarcomas. Here is a list of first-line and second-line treatment for osteosarcomas. Typically, first-line, we would treat with cisplatin and doxorubicin, or high-dose methotrexate, cisplatin, and doxorubicin.